A warm welcome to one and all. This is Dr. Sunil Manuel, Associate Professor from the Department of Orthopedics. The topic that we'll be covering today would be regional conditions of the wrist and hand. So here in this slide are the various conditions that we commonly come across in the wrist and the hand. The chief condition that we have here is the carpal tunnel syndrome. Along with that, we'll also be discussing about the Dupuytren's contracture, mallet finger, trigger finger, de Quervain's tenosynovitis, and ganglion. Moving on to slide number 3. So this is about carpal tunnel syndrome. So this condition was first described by James Paget, and it's a result of compression of the median nerve within the carpal tunnel. So we've all heard of the carpal tunnel, the tunnel in the volar aspect of the wrist. What we see here is that the carpal tunnel is a fibro-osseous canal. So I'll repeat the word. It's a fibro-osseous canal, which means some parts of the canal are lined by fibrous tissue and some parts of the canal are lined by bones. And the chief structure that we are worried about here in this carpal tunnel is the median nerve. Of all the structures within the carpal tunnel, basically we have a few tendons. I'll name them later. Along with that, we have the median nerve. So if there is an increase in contents within the carpal tunnel, or if there is an increase in pressure because of some idiopathic conditions within the carpal tunnel, the tendons are not so much affected because of increased pressure, because they are resilient to pressure. The chief structure that is compressed is the median nerve. This is very similar to what happens in the closed compartment of the brain, where either with edema or with bleed, we know that when the neural tissue is compressed, then that can lead to deleterious effect. The same way as the median nerve is compressed in the carpal tunnel, we need something called an axoplasmic flow within the axons of the cells. So basically what we have here is we have the cell bodies of this median nerve located either in the spinal cord, that is in the cervical spine, or in the dorsal root ganglia in the neck. From there we have these long axons which comes all the way up to the tips of the fingers and innervates the upper limb. But most importantly, from the cell body all the way up till this axons, there is something called a flow of cytoplasm, and in the neural cells this cytoplasm is called axoplasm. So whenever there is a compression on the nerve, then what happens is the chief problem that we have here is we have limitation or we have complete blockage of the axoplasmic flow. This axoplasmic flow is very important for maintaining the normal cellular health of the nerves, and this is what happens in carpal tunnel syndrome. Moving on to slide number 4. So here we have the boundaries of the carpal tunnel. So first we'll start with the roof of the carpal tunnel, and the roof is the most important boundary of the carpal tunnel, simply because this is the boundary that is mainly fibrous or made up of fibrous tissue, and any pressure within the carpal tunnel is going to be approached to be released by the surgeon by decompressing the roof. In other words, we will de-roof the carpal tunnel and therefore release the pressure from the carpal tunnel. So what are the structures that make up the roof of the carpal tunnel? Mainly it is the flexor retinaculum of the forearm continued into the hand. So what are the components of this flexor retinaculum? So the components of this flexor retinaculum are from proximal to distal. So proximally what happens is you have, as the deep forearm fascia comes into the wrist, there is a slight thickening. This blends with the transverse carpal ligament exactly over the carpal tunnel, and as we go even distally, we find a small aponeurosis that connects the thenar and the hypothenar muscles. Now why is all these three important? For a practical purposes, for a student to know, all that he needs to know is that the roof of the carpal tunnel is the flexor retinaculum. But these 3 points under the flexor retinaculum are important for a surgeon, so that whenever he releases the carpal tunnel, he cannot go off just releasing the transverse carpal ligament over the wrist. He also has to take great care to ensure that the deep forearm fascia that is in touch with the transverse carpal ligament as well as the aponeurosis between the thenar and the hypothenar muscles is also released. Because otherwise what would happen is just releasing the transverse carpal ligament over the wrist would lead to incomplete decompression of the carpal tunnel, and therefore incomplete decompression surgery, and therefore can lead to a failed surgery. So this is something that a student has to understand very well. Moving on to slide number 5, here I have put the other boundaries of the carpal tunnel, which would be the floor, the medial wall, and the lateral wall. And here we have got a cut section picture, and the picture is self-explanatory. Mainly the medial and lateral walls as well as the floor of the carpal tunnel is mainly formed by bones. So we need to know that. Surgically speaking, these walls are not so important because the surgeon has no way of decompressing the carpal tunnel through these approaches, and therefore the roof becomes the most important structure for release of the carpal tunnel pressure. Moving on to slide number 6. So here I have put the contents of the carpal tunnel. As a simple rule of thumb, you just have to remember that there are 10 structures within the carpal tunnel. So basically, what are those structures? So these 10 structures can again be divided into two: tendinous structures and neural structures. So 9 of them are tendinous structures, and just there is one neural structure, which is the median nerve. And amongst these 9 tendinous structures, once again you can divide them into two, basically based on the sheath that is covering the tendon. So on the medial side you have something called an ulnar bursa, which is marked here in green, which encompasses the tendons of flexor digitorum profundus and flexor digitorum superficialis. And basically we have 8 tendons here, because these tendons are the tendons supplying the 4 fingers of the hand except the thumb. So once again I'll repeat, there is a sheath of synovium. You need to remember these words very carefully. There's a sheath of synovium called the ulnar bursa, which encompasses the 8 tendons of the flexor digitorum superficialis and the flexor digitorum profundus. And also on the radial side we have one single sheath of synovium that is called the radial bursa, and this encompasses the tendon of the flexor pollicis longus that goes towards the thumb. So that completes the 9 tendons, and obviously the median nerve is the last structure in the carpal tunnel. Moving to slide number 7. So basically I have put this something called the 11th structure. So there is always a confusion about the position of the flexor carpi radialis in the carpal tunnel. So this picture should make it very clear that the flexor carpi radialis is not a content of the carpal tunnel. Basically the roof of the carpal tunnel splits into two laterally and encompasses the tendon of the flexor carpi radialis, which I have marked in red color, and therefore there should not be any confusion that this is a content of the carpal tunnel. Moving to slide number 8. The big question now is, what causes a carpal tunnel syndrome? So let me make it clear that the most common cause of a carpal tunnel syndrome is idiopathic. That is, the cause is not known. Having understood that, let's also move on to some structural causes of carpal tunnel syndrome. As we move on to slide number 9, there are some conditions that can decrease the size of the carpal tunnel. So one common condition that we see is when a person is doing activities that require him to have his wrist flexed or extended for a prolonged period of time. So why is flexion or extension of the wrist for a long period of time? What does it do? Normally the carpal tunnel pressure increases on either flexion or extension of the wrist. So as part of our routine activities, when we do these movements, there is no problem. But when there are movements when there are instances that require us to keep our wrist flexed or extended for a prolonged period of time, there is a high chance of the person ending up in carpal tunnel syndrome. So most commonly we see in people who are doing desk jobs. Slide number 10 puts up some other causes where there is increase in the contents of the carpal tunnel. So some of the common causes are forearm and wrist fractures, either due to a hematoma which is seeping into the carpal tunnel, or structurally due to displacement of the fracture fragments. Also, we can have higher carpal tunnel pressures or carpal tunnel syndrome because of dislocation or subluxation of the wrist. Slide number 11 shows some inflammatory conditions like rheumatoid arthritis and gout, and we also have some conditions where we have alteration in the fluid balance like in hypothyroidism and pregnancy. I just want to point out that the conditions that I have marked or highlighted in purple are conditions that we commonly encounter in clinical practice. And the other thing about pregnancy causing carpal tunnel syndrome is whenever a patient presents with carpal tunnel syndrome and pregnancy, we wait for the delivery, and usually the condition is self-limiting and the condition resolves by itself after delivery. Moving on to slide number 12. So we have something called the 50-50 rule of advertising and the 80-20 rule of life. I'm sure most of you are familiar with this. So let me explain. So most advertising companies or most manufacturing companies, so they understand this 50-50 rule of advertising. So of all the money that is spent on advertising, all companies accept that 50% of the money is a total waste, but at the same time the other 50% is totally effective. Unfortunately, they cannot get more efficient because they don't know which 50% is waste and which 50% is more effective. Similarly, what does the 80-20 rule of life say? So to achieve 80% of the work or of the activity, all that we need to do is put in 20% of the effort. But the last 20% of the efficiency or the work completion would probably require 80% of effort. So we must have seen or encountered this thing in many life scenarios. Now the diagnosis of carpal tunnel syndrome also follows the 80-20 rule. So when I see a patient, from the clinical examination and from the clinical findings, it's obvious to me that it is an idiopathic carpal tunnel syndrome, or it's obvious to me that it's a carpal tunnel syndrome, and it's also obvious to me because idiopathic carpal tunnel syndrome is the most common condition. After having ruled out the structural causes, it's obvious that it is a carpal tunnel syndrome. So making a diagnosis of carpal tunnel syndrome just requires 5 to 7 minutes. However, the problem or the effort comes in before taking up the patient would be to rule out a structural cause or a secondary cause of carpal tunnel syndrome, and that takes 80% of the effort. So as I will tell in the following slides, we need to take the patient through a series of imaging investigations to look for any structural causes of carpal tunnel syndrome without assuming the fact that all carpal tunnel syndrome is due to idiopathic effect. Moving on to slide number 13, the chief symptoms of carpal tunnel syndrome would be tingling and numbness in the hand. So only an intelligent patient would be able to tell you that the tingling and numbness is there only in the medial fingers or the lateral fingers. Most other patients will just tell us that there is a severe tingling and severe numbness in the hand, and most of these symptoms are heavy or severe at night. As the condition progresses, the tingling and numbness can be replaced by pain, and that is not a good sign. And with even more progress, we can find that the pain disappears. So when the pain disappears, we have a problem. If it's progress of the condition, then that shows that there is a neurological deficit. The patient is probably going into neurological deficit. Added to that, the patient can also present with clumsiness of the hand. That is, the agility or the fine movements of the hands are restricted, and the patient feels a little stiffness, and the patient finds it difficult to do his day-to-day activity. Moving on to slide number 14, the signs, the predominant sign would be paresthesia in the median nerve distribution in the lateral 3.5 digits. So I told you, as far as the symptoms is concerned, the patient is just going to show us the entire hand and tell that the patient is having tingling and numbness. But when it comes to eliciting paresthesia, it is our clinical examination that comes in. So how do we carefully examine for paresthesia in these fingers, that's in the lateral 3.5 digits? The first thing would be to take both the hands of the patient and show the patient by comparison that the area that the patient is symptomatic has got a different sensation as compared to the opposite side. That's the first thing. And the other thing is also we need to differentiate between the ulnar nerve distribution and the median nerve distribution. So what we do as a simple rule of thumb is we show the patient that the sensation is different in the little finger as compared to the index finger. So the little finger, especially the palmar side, is the autonomous zone for the ulnar nerve, and the index finger, the palmar side, is the autonomous zone for the median nerve. And therefore when we show the patient the difference in sensation, that is where the patient will be able to agree with us and tell us that yes, there is a difference in the sensation. So here we need to really sit with the patient and do a careful clinical examination. Added to that, we can elicit a tingle sign, that is tingling, a tingling sensation along the entire distribution of the nerve by tapping the median nerve at the level of the carpal tunnel. In late stages, as the disease progresses, there can be some patients who present with a thenar muscle atrophy, and and also, as I mentioned before, in the late stages the patient can even present with complete anesthesia. Thankfully for carpal tunnel syndrome, the good thing is the patient is so symptomatic in the initial phase before he goes into neurodeficit that the patient will eventually end up with the physician, and therefore a right diagnosis can be made at the right time before the patient goes for permanent neurological deficit. Moving to slide number 15. So we use the clinical examination called Fallon's sign, what we do is we do a complete flexion, an acute flexion of the wrist, and sustain it for more than 60 seconds. Because what happens normally is the patient has these symptoms at home and predominantly at night, but the time that the patient comes to the hospital, to the OPD, it would be the day, and probably the patient is not so symptomatic. So at that point of time, what we do is we do this Fallon's test where we flex the wrist, and by keeping the wrist flexed for up to 60 seconds, we may be able to elicit paresthesia and pain. And that's a very good diagnostic test before sending the patient for any imaging examination. Moving to slide number 16, the diagnosis before we go for imaging, I just want to emphasize once again that the diagnosis of idiopathic carpal tunnel syndrome is essentially a clinical diagnosis. The imaging, how is it helping us? The imaging is helping us only to look for any structural abnormalities that is leading to a carpal tunnel syndrome, and if so, we need to take care of the structural abnormalities. So slide number 17 shows the different imaging modalities that we use. So for all practical purposes, when patient comes to us in the OPD on an OPD basis, after making the clinical examination and after making a clinical diagnosis, basically for all patients we send only for a plain X-ray of the wrist, and we do a ultrasound of the wrist. And in the ultrasound, if we are able to do a dynamic ultrasound of the wrist, then that's going to be very useful. If the plain X-ray or the ultrasound shows any abnormality, and if the abnormality is a bony abnormality, then I would be interested in doing a CT scan of the wrist. If the abnormality on the ultrasound is a soft tissue abnormality, then I would be interested in doing an MRI of the wrist. Nerve conduction studies pertaining to the median nerve distribution or the median nerve are definitely objectively useful, but they are not at all as sensitive and specific like the clinical examination. But the fun part that I would want to emphasize here is it all depends on where the patient lands up. If the patient looks at his symptoms, Googles it, and finds out that it's a neurological condition, and if the patient by any chance, not any chance, many of the patients do end up with a neurologist, and if the patient ends up with a neurologist, then the investigation would be in the reverse order. The first investigation would be nerve conduction study, which is totally useless for a surgeon who is planning decompression of the carpal tunnel. But obviously, because the physician here involved is a neurologist, he will first be doing a nerve conduction study, then he would be following it with an MRI and or a CT scan. So that is where the problem is, and eventually the patient will get referred to us for decompression. Slide number 18, I have put a picture of the dynamic ultrasonography and how it is done. So basically here we are looking at the width of the carpal tunnel, and we are also looking at the position of the nerve in a ultrasound. And before that, let me emphasize that ultrasound is a beautiful investigation, good enough for making a diagnosis of carpal tunnel syndrome. And so here what the sonologist will do is they will take the patient's wrist through different movements, flexion, extension, finger folding, finger extension, and they will look at how the different movements are reducing or increasing the size of the carpal tunnel, and also the way in which the nerve is compressed. Moving on to slide number 19. So how do we manage a carpal tunnel syndrome? So initially we go for the medical management, and if it fails we go for surgical management. Now one thing that you should always understand here is, I told you about making the differentiation between an idiopathic carpal tunnel syndrome and a structural carpal tunnel syndrome. So the 80% effort that we put in getting all the investigations done for the patient is basically to rule out a structural carpal tunnel syndrome. Why? Because my first line of management in an idiopathic carpal tunnel syndrome would be medical management. However, if the patient has a structural cause that is causing carpal tunnel pressure, increased pressure and pressure on the median nerve, then no medical management is going to help. The patient requires a surgical management. So this differentiation is aided by doing the investigation and also the clinical examination. This is the reason why I am repeatedly emphasizing on clinical examination, because at the moment we do our clinical examination, get our clinical examination right, then everything else is secondary. In fact, the first 5 or 7 minutes that we spend with the patient looking at the symptoms and looking at the signs is good enough to make a plan or a roadmap for the patient's treatment. But where we are going to be fooled is when somebody walks into our OPD and then keeps an ultrasound report or keeps an MRI report on our table, and even if we ignore it, they will open the report for us and thrust it on your face and tell you that, sir, I have a carpal tunnel syndrome. So at that stage, what happens to most surgeons is like, okay, he's got a carpal tunnel syndrome, so decompression. It doesn't work like that. Basically what happens is understanding the symptom, understanding the stage of the disease where the patient is, all those things no investigation is going to tell us. It's only going to be told to us by spending time with the history and with the clinical examination. The investigations will always remain. The investigations can always be referred back to. If the patient doesn't have investigations, we can get it done, but nothing supplements or nothing replaces the clinical examination and the initial diagnosis. So once we have made that initial diagnosis, then we can take the patient through medical management. So the first thing, the most important thing that I would emphasize when people come to me with carpal tunnel syndrome would be activity modification. I want to clearly understand what is it that led to this person having this idiopathic carpal tunnel syndrome. Is there any specific activity that the person is repeatedly doing that is putting this person at high risk for carpal tunnel syndrome? I can probably say that I have saved at least 2 dozen people from undergoing surgery simply by helping them modify the position of their keyboards when they're using computers at work. So that's as simple as that. But it really requires a lot of lateral thinking. Otherwise, what happens is it's so easy. It's a simple surgery, just a 15-minute surgery for us, and we are all done with it. But I've tried to understand and try to take patients through their day-to-day activities, because even after doing the surgery also, the patient is eventually going to go back to the same work routine. And if there is a peculiar wrist position or because of the problem of the position of the keyboard, then the patient is going to land up with a carpal tunnel syndrome in the opposite wrist. So prevention is better than cure. So simple thing, modify the activity, find out what activity is causing the carpal tunnel, and try to restrict the patient from doing that activity. That's one thing. The other thing is night splints. Absolutely helpful. Basically, the problem with carpal tunnel syndrome, one of the reasons for why the patient gets more pain at night. So, there are two reasons for the patient getting more pain at night. The first reason is that most neurological or neuropathic conditions, especially of the peripheral nerves, are more painful at night. The second reason is during the night or when the patient goes to bed, the patient does not have much control over the wrist or the position of the wrist. The patient can sleep a whole night. If it need not be for patients, it's for all of us. We can sleep a whole night with the wrist in completely flexed position or completely extended position. Sometimes the wrist and the hand go under our bodies, and therefore these positions worsen a person's condition who is already having a carpal tunnel syndrome. So if you can give a small splint or a removable splint that the patient can self wear just before going to bed, and if the patient goes to bed, then you can be 100% assured that the patient is keeping the wrist of that hand or of that upper limb in the neutral position throughout the night. So I have found a really good help by giving patients night splints, along with of course anti-inflammatory medications and anti-inflammatory modalities by physiotherapy. And I should say probably 40 or maybe even 50% of patients you can avoid surgery by taking them through these three steps of medical management. Moving on to slide number 20, what are the indications for surgical management? So the first indication would be a failure of treatment on the by using the medical management. That would be the first indication. The second indication would be any structural causes of carpal tunnel syndrome. So in the beginning itself, I told that any structural cause, we do not try medical management. We can directly go for surgical management. And the third indication would be emergence of any neurodeficit in the upper limb. To be more specific, it would be emergence of neurodeficit like anesthesia or muscle weakness in the hand pertaining to the median nerve innervation. Now, one important thing that I would want to emphasize here is that a sensory deficit in the hand, especially an anesthesia in the hand, is not acceptable, because hand itself is a sensory organ, and therefore we need to be very aggressive with the surgical release or management of the condition. Moving on to slide number 21, what is the surgical management that we do? The surgical management essentially is releasing the carpal tunnel. So what do we mean by releasing the carpal tunnel? Surgical release of the carpal tunnel would be to de-roof or release the fibrous structure that is there in the roof of the carpal tunnel. So how can we do this? We can do this either by an open surgical release, or these days we can even do it with the use of endoscopic surgical release. Slide number 22 shows a schematic diagram of an open surgical release. When we are doing the open surgical release, we are able to clearly see the transverse carpal ligament, and we are also able to see the other two components of the carpal tunnel, that is the distally the aponeurosis between the thenar and the hypothenar muscles, and proximally the distal forearm fascia. And every effort has to be done to do a complete release. The problem here is we need to be able to see the median nerve in the entirety, and normally what happens is when we open and check on the median nerve, we will see a characteristic feature of a dilatation or a swelling of the median nerve just proximal to the beginning of the carpal tunnel or proximal to the area of pressure. This itself indicates what I told in the beginning about blockage of the axoplasmic flow. The median nerve itself is supposed to be having blood vessels on the top of its surface, but in the area with pressure, we will be able to see that the median nerve looks extremely pale, with shutting down of the blood vessels that are supplying the median nerve. So these blood vessels are called vasa neurosa. So putting all this together, once we open, we will be able to clearly see that the median nerve was under pressure, and we will be also confident that we have released the median nerve in its entirety. So the other thing is that even if we leave 1 or 2 millimeter bands of the carpal tunnel roof, then that can lead to a secondary carpal tunnel syndrome or a recurrence of the condition. So the advantage is we will get a good visualization, and we should never hesitate to take the incision proximally or distally if there are any tight bands. Slide number 23 shows the exact extent of the incision. So this is the standard incision, and our incision most likely we would need only such a size. And the beautiful thing about any incision on the palm is that it heals without scarring. After doing the release, we will be closing the skin loosely with stitches, and we will be splinting the wrist. So the concept is open, release the carpal tunnel, but don't close it back with stitches. We keep it open inside, but the skin overlying that would be closed and a splint would be applied. This I have put in slide number 24. Moving on to slide number 25, there is a picture of how an endoscopic release of the carpal tunnel is done. Here, using an endoscope and taking a port from either proximally or distally, we are able to go directly into the carpal tunnel. So literally the scope will be inside the carpal tunnel along with the median nerve, and from there, using the camera of the endoscope, we are able to see the roof of the carpal tunnel. That means from inside we are able to de-roof it, and then use a knife to remove the uh, roof of the carpal tunnel. So here the advantage is there is no skin incision over the carpal tunnel. Slide number 26 shows how an endoscope is being used to release the carpal tunnel. The great advantage here is there is no skin incision, and the patient can return back to activity, full activity immediately. So that is a good advantage of endoscopic release. However, there is a small disadvantage of doing a partial release or leaving some fibrous bands, because the surgeon is not very sure whether he has released completely. But again, like in most minimally access procedures like endoscopy and arthroscopy, over a period of time with increasing surgeon's confidence, uh, surgeons should be able to do a complete release of the carpal tunnel using the endoscopic method. So the endoscopic method is slowly gaining popularity, but it's not available in most centers. Moving on to slide number 27. So there is always this debate between open versus endoscopic release, and therefore some studies, the result of current studies are like this. The functional result of both open surgery as well as endoscopic surgery is the same at 6 months. That's the first point. However, as I mentioned before, endoscopic surgery patients can have the advantage of returning early to work as compared to open release surgeries. And however, there is again a problem of slight increase of the incidence of recurrence with endoscopic surgery. Initially, as the scope is being pushed in and sent into the carpal tunnel, as you can understand that it's a totally blind procedure. Therefore, there's a small risk of iatrogenic nerve injury also with endoscopic surgery. So that completes carpal tunnel syndrome. And with that, I end the session here. What we'll do is in the next session, we will do a few other minor topics in the wrist and hand, that is dupuytren's contracture, mallet finger, trigger finger, dequerens tenosynovitis, and ganglion. So the plan is to do carpal tunnel alone in one session and bunch up all these smaller topics in the next session. Thank you very much for your kind attention.